Thank you so much, Dr. Patel. Dr. Evidente. That was a great talk, and we got a number of questions from the audience that I would like to throw out to you. The first of which is, what are the ill effects of untreated obstructive sleep apnea? And when should it be treated? At what point should it be treated?
So the effects of untreated sleep apnea are quite numerous, right? Apart from what we discussed here in the setting of Parkinson's, I mean, having untreated sleep apnea alone, because of the repetitive drops in oxygen, can increase the risk of developing irregular heart rhythms like atrial fibrillation by 2 to 3 times. It can increase risk of developing hypertension, worsen hypertension, increase risk of heart attack, stroke, and there's even now a relationship with increased risk possibly of Alzheimer's disease. So if there's concerns of snoring, poor sleep, you definitely want to be evaluated. The sooner you can intervene and treat, the better the long-term outcome, because there's evidence also showing that the sooner you can treat the sleep apnea, prevent that, quote unquote, hidden damage on the brain and the body, that the better your overall life can be. Just like treating, diabetes or hypertension early as well. Most individuals don't necessarily feel those conditions, but it's more preventative.
And is obstructive sleep apnea more prevalent among Parkinson's patients?
No, as I shown earlier, that sleep disorders in Parkinson's are about similar in prevalence to the general population.
And then some of my patients are just not tolerant of CPAP, no matter what kind of masks they try. And I know for a fact that many of these patients just don't do very well with their Parkinson's if their sleep is not treated adequately. So what are the alternatives for such patients aside from Inspire?
So then the other option would be oral appliance therapy. So oral appliance therapy is a device that dentists would make, but in essence, it helps to extend the lower jaw forward. But even before then, because oral appliance therapy isn't as effective as CPAP therapy, but there's a lot of individuals, even without Parkinson's, that have a hard time tolerating CPAP therapy itself. And there's this different kind of machine called BiPAP. BiPAP actually has been around for 25 years. In fact, I use it myself, and it basically alters pressure between inhalation and exhalation. So it actually is much more physiologic to the way we naturally breathe. And a lot of these folks that had difficulty tolerating CPAP, when we transition them over to BiPAP, they actually do much better. Just because the machine's easier to breathe with, and we can usually use less pressure, and that can work quite well for both individuals with Parkinson's or non-Parkinson's patients.
And then, as far as your use of melatonin for REM behavior disorder, what are the usual doses that work in your experience?
So I usually use right away. I usually will start individuals on the extended release, and I usually will start them probably at about 5 milligrams. Usually tell them, go up to about 10 milligrams. And that usually works well. There's even one that you can, I think there's a company that makes one called REM Fresh. I believe it's a 2 milligram extended release, but that seems to work well as well. You can buy it on Amazon, and I believe you can even get it over the counter in the local pharmacies. But that's usually what I recommend, is usually 5 milligram extended release right at bedtime, up to 10 milligram. That usually works well.
And then I have a number of patients, maybe a handful by now, who use mega doses of melatonin of up to about 30 to 40 milligrams per night. Is this something that you would recommend?
I would say no, because even individuals without Parkinson's, when they take those high dosages of melatonin, one of the common things that they report back is just nightmares and bad dreams, right? So in the setting of individuals that may have RBD, it could potentially even worsen the nightmares or worsen RBD behavior. So we definitely don't want to use that high of a melatonin dosage.
Well, the good news is that so far, I'm not aware of any studies that have shown that that you can kill somebody with mega doses of melatonin. It's supposed to be a powerful antioxidant. It's something that's produced in your brain as well, which puts your brain to sleep when it's time to sleep, so to speak. What about for patients with the travel and go to a different time zone? Is melatonin something you'd recommend?
Yeah, absolutely. So, I mean, typically jet lag starts with minimum 3 time zone changes. And there is a whole protocol that can be instituted to treat jet lag and minimize the effects of jet lag. But I mean, the simplest thing is, taking melatonin usually about an hour to 90 minutes before the individual ideally wants to be asleep would be what we would recommend. Taking it right at bedtime necessarily isn't a good idea because it's not going to get into the bloodstream right away, right? Because even our intrinsic melatonin is released roughly starting about 2 hours before our habitual bedtime, which then slowly activates the process of sleep. So, we will advise individuals to take it at least 60 to 90 minutes before they want to be asleep.
Okay. And then for patients that take a good dose of melatonin and they're able to sleep, and then they wake up in the middle of the night and they have a few more hours to go before their actual or their usual waking up time, is it advisable to take a second dose in the middle of the night?
I do have a lot of patients that will try that, and majority of the individuals will report grogginess the next morning, when they wake a few hours later. So ideally, I would say no, just because most individuals would end up reporting that they feel groggy when they wake up a few hours later. So, but a common mistake that people make when they wake up in the early morning hours, and I think we're all guilty of it to some degree, is we'll just keep laying there thinking, right? And that ends up promoting the brain to learn to want to be more awake. So that's where behavioral therapy for insomnia can be, helpful to help basically retrain the brain not to want to become hyper alert at that moment, to where the individual can roll over and go straight back to sleep.
Yeah. And then what is the ideal number of hours before bedtime for someone to take melatonin to induce sleep?
I'd say roughly about 90. Like I said, for jet lag, we'll typically say 60 to 90 minutes, but for ideally, we'd say up to 2 hours.
Okay. And then there's another question here on oversleeping. So how much sleep is too much sleep?
Great question. So technically, anything above 8 hours actually is too much sleep. So there was actually data published in roughly 2010 showing that getting more than 8 hours of sleep per night, there was an odds ratio of about 1.5 to 1.9 times of increased risk of angina, heart attack, and stroke. So too much sleep, there is some issue in terms of the cardiovascular system where it can increase risk of angina, stroke, and heart attack. Obviously, getting less than 6 hours of sleep can increase the risk of angina, heart attack, and stroke by about 3.5 to 4 times. So obviously getting not enough sleep is much worse, but getting too much sleep or more than 8 hours is not good either.
Okay. And then what about Inspire? Is it covered by insurance?
It is. It is. So I've been working a lot with Inspire. I probably have about 40 patients with Inspire in the last year and a half. So there are specific criteria for meeting requirement for Inspire, but to date, I don't have any individual with either Medicare or commercial insurance or even access that have not been able to get approval for Inspire. But you have to have moderate to severe sleep apnea, obstructive sleep apnea, that is. So, the AHI, the number of times that the person's having sleep apnea must be anywhere from 15 up to 65 events per hour. There's a BMI restriction of less than 35 kilogram per meter squared. And there must be documented history of intolerance to CPAP or failure of symptomatic improvement with CPAP. And then there's there's an anatomical requirement as well that ENT determines. But once the individual meets these requirements, then it's not an issue with regards to insurance coverage.
Okay, and what kind of side effects have you seen in your 40 patients so far?
Just minimal, primarily just within the first month after implantation, because it's 2 incisions. There's a 2-inch incision in the right upper chest where they, implant the generator, and then there's a 2-inch incision along the right jawline where they attach the cuff around the hypoglossal nerve. Usually localized, irritation there. Typically, by the end of the first week, postoperatively, patients don't really have much issues at all. And I have an age range of about 40 to 83 that have had Inspire, and none of these individuals have had any long-term issues, at all. So,
yeah, that's great to hear.
Mm-hmm.
And then is if you don't get enough sleep at night, is the midday sleep as good as the nighttime sleep?
So it depends. Because if the individual's not getting enough good sleep because of sleep deprivation or an underlying sleep disorder that's preventing them from getting enough sleep at night, technically, when the individual sleeps during the day, that's usually the time that the brain is trying to recover lost stage 3 or REM sleep or deep sleep that it couldn't get at night. So technically, the daytime napping could be better quality sleep than what the individual got at night because of basically truncating themselves from getting enough deep sleep.
Okay, here's a question from another question from the audience. The iron level you mentioned earlier was 75. Is that the same as milligrams for restless legs?
Yeah. Mm-hmm.
Okay. Do you see any utility in using iron for RLS patients with no iron deficiency?
I haven't seen any. I haven't seen any benefit in recommending iron to patients that have normal ferritin.
Got it. I break up my sleep in 2 unequal portions, initially about 5 hours, and I wake up, exercise for 2 hours. Okay, then he tires himself with exercise for 2 hours and falls asleep for a number of hours until he wakes up in the morning. Is that an okay routine for a patient with Parkinson's?
It's not ideal. I mean, I guess the question I would have is what's waking you after 5 hours, right? If we could identify what's waking you at that 5 hour mark and treat that and allow you to sleep 7 hours straight, that would be more ideal than having the, quote unquote, kind of biphasic sleep schedule.
Can someone with a pacemaker also use Inspire?
Yes. Mm-hmm.
Okay. So any pacemaker, whether it be a brain stimulator, which is loosely speaking a brain pacemaker, as well as a heart pacemaker, are compatible with it. Obviously, you kind of have to put it on the other side, right?
Mm-hmm. Yep.
Okay. Let's see now. If I have some moderate trouble getting to sleep, would you advise melatonin? So what dosage would you recommend? I think you've answered this, but you want to just do a quick answer for this one as well?
Yeah, sure. So, I mean, it depends on, how long it's taking you to fall asleep. Remember, as long as you're falling asleep within 30 minutes or less, that's technically normal. But if you're just having a hard time falling asleep, then you may want to just consider short-acting melatonin, anywhere from 1 to 5 milligrams. The extended release melatonin, I typically recommend more so in individuals that have the RVD behavior because it covers into the second half of the night. You could take it about at least an hour, to 2 hours before you want to be asleep.
Got it. And then for your senior Parkinson's patients with DDS, does a wedge pillow help in the breathing and lessen the coughing and loud snoring?
I mean, it could help to some degree, but if the individual is snoring and coughing, then that would highly suggest that the person likely has underlying obstructive sleep apnea, and that really needs to be identified and treated effectively. Even individuals without Parkinson's that have sleep apnea, sleeping elevated, even in a elevated mattress, doesn't necessarily overcome the sleep apnea completely. It helps to reduce the burden to some degree, but I mean, we've studied individuals in hospital beds at a 45-degree angle, and they still continue to snore and have sleep apnea. So ideally, you should be evaluated and treated effectively. So.
I have many patients, whenever I query them about restless legs, many of them say that they do have RLS, when in fact, when I ask them about the details, they talk about jerking of the limbs at night. So can you help the audience differentiate between true RLS versus periodic limb movements of sleep?
Yeah, absolutely. I hear that quite often as well. A lot of individuals are diagnosed with restless leg syndrome during a sleep study, which actually can happen. Exactly. So restless leg syndrome is a disorder where you feel the symptoms and report them to us, right? So when you get into bed at rest and you're laying there, you can feel a sensation of discomfort, itchiness, creepy crawly sensation along your legs. A lot of individuals report, I just have this hard to explain anxiousness in my legs, and it forces the individual to have to get up and walk around, and when they move, the symptoms basically subside, and then when they get back into bed, the symptoms may come back again. So then they're getting in and out of bed, fighting these symptoms. So that's restless leg syndrome. Once the individual goes to sleep, restless leg syndrome disappears. It may come back when the individual wakes up in the middle of the night, but again, they're awake. Periodic limb movements, the jerking during sleep, that's an involuntary movement that only happens when you're sleeping. So the individual that's doing the movement typically won't know they're doing it because the movement occurs before the individual wakes up, right? The bed partner may notice those movements. So that's periodic limb movement during sleep. They're involuntary movements that only occur when you're asleep, and they disappear when you wake up. RLS only occurs when you're awake. It disappears when you go to sleep.
Got it. Okay. And then there's a question here on whether melatonin high doses can lead to blood clots. I think I know the answer to this, and the answer is yes. There's been some case reports of blood clots in your legs, and sometimes leading to pulmonary embolism from high doses of melatonin. So it kind of increases the clotting in some patients. Although it's not a very common thing, but it's been reported. Okay, another question I received was, does CPAP alleviate restless leg syndrome?
That's a great question, actually. So short answer is yes, it may. So one of the things in patients with RLS that can greatly aggravate RLS, apart from alcohol, nicotine, diet, sleep deprivation, is poor quality sleep. So I have a lot of individuals that I'll see that have really significant RLS symptoms that have often failed the typical medications like ropinirole, pramipexole, carbidopa, levodopa, but they've never been evaluated. But once they fall asleep, their sleep quality is not very poor, but no one's ever evaluated their nocturnal sleep. And many of these individuals actually turn out to have underlying sleep apnea. Once you treat the sleep apnea successfully with CPAP, improve their quality of sleep, that alone can help to improve the RLS symptoms quite significantly. I've had many individuals where just by treating their sleep apnea alone, their RLS symptoms have minimized so significantly to where they're falling asleep within 30 minutes. Maybe once a week, they may feel a little bit of restlessness, but nothing to the degree that they did before the sleep apnea was treated. So we really don't even have to use any medication to treat their RLS. So absolutely, it can.
Okay. And then how do you feel about giving melatonin to children to help them sleep at night? So what's your minimum age for melatonin? Is there such a pediatric dose for kids?
That's a great question. There really isn't. There's one thing I have a 2.5-year-old. So, and being a sleep doctor, my son didn't sleep the greatest in the very first year of life. So then, I kind of went on the mission of trying to figure out what I could do with him to help him. So one thing to keep in mind, there's a lot of pediatric melatonins available over the counter. A majority of these liquid preparations actually have alcohol in them. So that's one thing I've been counseling a lot of my parents is just make sure if you want to try melatonin, definitely less than 1 milligram for certain, but make sure the preparation doesn't contain any kind of alcohol. Because the last thing you want to do is give a child alcohol. If melatonin doesn't work, one thing that we will do is we'll actually use hydroxyzine in the pediatric population. It actually works quite well. Hydroxyzine works quite well. So that's the only thing from a prescription standpoint that I'll ever use. I have used gabapentin in pediatrics, but that's in the setting of pediatric PLMD, where the ferritin wasn't an issue, believe it or not. And that can work well as well. But obviously you want to dose it based upon their weight. There's a liquid preparation.
Okay, another interesting question from the audience. How do you treat Parkinson's patients sleeping with their mouth open?
There's an over-the-counter chin strap that can help. If the individual is a mouth breather, if they happen to snore, then you need to rule out sleep apnea. Because mouth breathing is a very common thing that happens in individuals that have upper airway restriction because of sleep apnea. So it's viewed to be a mechanism by which the brain helps to open up the airway, given that there's some collapsibility. And I'd say even in individuals with sleep apnea, if 100 individuals pre-treatment are mouth breathers, I'd say roughly about 40 to 50% of them will stop being mouth breathers after we treat the sleep apnea. So.
Okay, what about bruxism? What's the difference between bruxism and jaw opening? I think that's the opposite, but you want to answer that?
Yeah, so bruxism is actually teeth grinding or jaw clenching. So that would be the opposite of being a mouth. So, but yeah, bruxism actually is viewed. So bruxism actually has been shown initially in the pediatric dental literature about 8 years ago now to be a common symptom of untreated sleep apnea, but even it was later described to be the same in adults as well. So bruxism for us, if it's unrelated to sleep apnea, then of course, we have to have the patient, meet with the dentist to get a night guard to wear. But I have had a few individuals in the past where they had disrupted sleep. We did the sleep study. The only thing that we discovered actually was bruxism. They had no evidence of sleep apnea, no snoring, but every time they would clench, they trigger an arousal. Sure. And once they started wearing a night guard, it actually stopped the arousal and their quality of sleep improved. that scenario is not a very common scenario where you see bruxism without the presence of sleep apnea. But in that individual, and those few individuals, using an iCard helped to improve their quality of sleep quite significantly.
Yeah, terrific. Do you recommend carbidopa levodopa extended release to assist with sleeping in Parkinson's patients?
I guess it depends upon the, if there's significant movements that could be affecting the quality of sleep. But there is literature showing that a long-acting dopamine agonist can be beneficial, especially with levodopa, carbidopa, can improve quality of sleep if there's motor symptoms that could be impacting the sleep.
Does levodopa help restless legs or periodic limb movements of sleep?
It can. Mm-hmm.
Okay, there you go. Maybe that's one reason to use sustained release levodopa before they go to bed. Mm-hmm. Okay, other things. What about CBD oil or medical marijuana for sleep? That's a good one.
Anecdotally, we hear, I think we all hear anecdotal evidence from our patients that are on it for chronic pain that there's a relaxing effect and it makes people drowsy. Officially, we really don't have any comment because it's still a class 1 drug, especially the cannabis-based CBD and THC. There's no real clinical studies out there that can provide us objective data to support the use of cannabis as a sleep aid. And if anything, the American Academy of Sleep Medicine has come out, I think last year, the year before, recommending against the use of it as a sleep aid. So,
okay. And then what is your favorite sleeping pill if melatonin does not work?
Actually, gabapentin. Gabapentin is the one that I'll commonly use. Yeah, because it doesn't have the addictive nature like the benzodiazepines. It doesn't have the amnestic events like Ambien can, and it has a nice calming effect. It's a mood stabilizer, so a lot of individuals that have a hard time falling asleep, a lot of them have comorbid anxiety, so it can help in that respect as well. So you always have to be mindful of the side effects, but in general, it works. It works relatively well.
What are some of the more common medicines that can trigger drug-induced REM behavior disorder or dream acting?
Most common are going to be antidepressants, especially the SNRIs. Those are the most common ones because they can trigger REM rebound effect, and that will greatly trigger and aggravate RBD.
And then there's another question here. If somebody has been dream acting all his life, is that a marker for a synchronopathy? In other words, it's not of recent onset. They've been doing this since they were younger. So is that a bad thing?
Not necessarily. But you also have to question, is it truly RBD, dream and active behavior, or is it, the result of, say, sleep deprivation? Because there's a lot of individuals that we'll see that will have untreated sleep apnea or sleep deprivation, and they'll act out their dreams. But when we do their sleep study, they won't actually have evidence of RBD, meaning they're paralyzing themselves when they're in REM sleep. We don't see any activity. So if anything, it's more REM rebound effect related. So when individuals are not getting sufficient REM sleep, when the brain has an opportunity to recover lost REM sleep, the thought is that the brain may enter into REM sleep so quickly that it may not fully paralyze you all the time, so you may be able to act out.
Right.
So short answer would be no, it doesn't necessarily mean that the person's developing alpha-synucleinopathy if they've been having dream enactment their entire life.
Okay, wonderful. And then is all dream acting REM behavior disorder?
No, just as I mentioned to the previous question. So it doesn't have to be. So, but the way you have to differentiate is actually you have to, because for RBD diagnosis, you have to have a clinical history of violent dream enactment behavior, recollection of violent dreams. But then the key thing also is objectively looking during a PSG if they're actually having REM sleep without muscle atonia or not. And if they are having REM sleep without muscle atonia, then yes, they have a diagnosis of RBD, but it could be idiopathic or it could be secondary. So not all individuals with RBD necessarily will go on to develop an alpha-synucleinopathy, but a good majority from what I've seen over the last 10 years have.
So if there's any concern as to whether the dream acting is occurring in REM versus non-REM sleep, do you recommend that a sleep study be done then? Mm-hmm. Absolutely. I agree. Okay. Wow, that was a lot of questions. Great answers. Some of these are really tough questions.